All right. Thank you, Gary, for the introduction, and thank you all for joining us today. Dr. Neu and I will be presenting a series of cases to our awesome panelists who are going to tell you a little bit about how they approach the case and how they think about the case. In the interest of full disclosure, the panelists have not seen the cases, so they don't know what's coming to them. So we'll really get to hear how they think and approach a case in their clinical setting. And just our standard PTC disclaimer that you guys have seen many times so far. So I have the first case. So the first case is Trent. Trent is a 22-year-old male who's a longtime patient of our sexual health program. He's been on HIV PrEP for the last 5 years and recently switched to long-acting injectable with lenacapavir. He's had gonorrhea, chlamydia, and syphilis in the past 2 years, and he started on doxypep about 6 months ago. He walks into our sexual health clinic with generalized intensely itchy rash on his abdomen and extremities. It started about 5 days before he came in, and he'd had 6 new partners since his last visit. This is a picture of what the rash looked like, and he actually had similar lesions to this on his buttocks and genitals. So we'll throw it out to our presenters. What's your differential diagnosis? What are you thinking about in this case? Maybe we'll start with Christine, who just came off mute.
Yeah, one of my first thoughts here, because he just switched to lenacapavir, is whether or not this could be a drug reaction, especially with it starting on the trunk and being quite itchy and the appearance of the rash. So I'm thinking about drug reaction. Also considering syphilis, of course, with having new sex partners, but it does not look typical for a syphilis rash.
Jason, can we go back to the image?
Of course.
So I completely agree with Christine that you've got to think about drug reaction, particularly given the site here where it looks like it's kind of adjacent to where that len goes in the abdomen, potentially. And is this related to that? But there's this lesion on his arm and his back, right? And so these are circular. I'm so old school. Like, you got to describe the lesion. So these are circular. They look largely macular with a raised edge, erythematous lesions that are not confluent. And just because he comes into the STD clinic doesn't mean this is an STD. And I'm wondering about tinea.
Okay.
You're rubbing up on people, you're going to the gym. Is this just something really boring? But I think that to Christine's point, like, you've got to think about this. The other thing that I always want to throw out to us when people have new rashes is acute HIV. And when I think about someone on PrEP, I always worry about acute HIV that we're going to miss. Lenacapavir, though, the rash that comes with acute HIV really comes with that super high viremia. And while we don't have a lot of data on len and HIV acquisition on len, we know it will happen at some point, but it's probably not going to look like it does for someone who's not on PrEP or who's inconsistently adherent to oral PrEP. And so I wouldn't expect this to be the rash of acute HIV. It also doesn't look like that rash.
Danny, do you have additional thoughts?
I have to agree with the other panelists. I initially had a much broader differential, but as you showed the picture, I was quite worried about tinea as well.
Yeah. So I think that's great. And I will say once again, we chose cases that had good differentials for a reason, because we wanted to hear how we think about it. And I think that's exactly the differential for this case. One other thing just to highlight is that we are doing next week a PTC dermatology series. So just to highlight that, and I'm sure the link will be sent out after this meeting, but come to that to learn about more dermatology things. But in this case, I think that's a really good differential. But I want us to think a little bit about emerging infections with dermatophytes. So things like ringworm, traditionally mild and treatable with antifungals. And there's increasing global reports of severe, hard to treat cases, as well as the emergence of antifungal resistant strains. So this is, we typically think about common ringworm being trichophyton rubrum, but we're seeing more and more trichophyton indotineae in the US, and particularly trichophyton mentagrathites genotype type 7 or TM7, which is the one I actually wanted to highlight here because we've been seeing more and more of this across the US. It started first in New York City, like a lot of things do, but there's also an outbreak right now in Minnesota, and there have actually been several other outbreaks across the US. These were first reported in Spain in 2020 through 2025, and they were really occurring primarily in men who have sex with men, either living with HIV or taking HIV PrEP. They were, just like we see often, frequently related to STI co-infection. So people would have this as well as gonorrhea, syphilis, chlamydia, and mpox. And the common sites were often the genital and buttocks areas. And patients actually needed long courses of antifungals to improve. In France, they saw more cases of this in 2021, 2022. Again, very similar. And unlike other trichophytin, was not linked to animal exposure, it really was person-to-person contact, primarily during sexual contact. And we had the first confirmed New York City cases here in New York City, where I'm located, in April to July of 2024. All were men with recent sexual contact. And if people had seen the MMWR, I actually stole that photo directly from the MMWR. So sorry, guys. That was our photo there. I do want to highlight that while we think about TM7, we do need to keep our differential even amongst trichophytin wide. We are starting to see US trichophytin endotyniae cases, including a couple of cases in women, and one case associated with sexual contact in a returning traveler. And so something to keep in mind, because it's not something we typically think of as an STI, but something we're seeing more and more, especially here in New York City. So with that differential in our mind, or at least the rash that looks like trichophytin, what tests would you consider doing next? Or do you even need to do any workup?
With the concern for resistance, you could consider doing a scraping and sending it to the lab for a culture and susceptibility.
Yep. And that's actually what I want to encourage people to do. Traditionally, we've often treated these people empirically with antifungals, but fungal cultures take a really long time to come back. And if you end up with a resistant one, what you don't want to do is wait 2 or 3 weeks, find out that the patient's not improving, and then send your fungal culture. So I do sort of want to encourage people to think about fungal culture up front, even though it won't come back for several weeks, as we are seeing more and more of these resistant pathogens. So we have a poll for the audience here, and then we'll ask our panelists what they think. But what, if any, treatment would you provide the patient at this time? So he comes in, he has the rash. We don't actually know what it is yet. What would we provide for treatment? All right, so 53% said a topical antifungal, about 20% said fluke, 20% terbinafine, 4% ITRA, and 4% no treatment at this time. Panelists, what would you guys do in your clinic?
So I did this yesterday.
Nice.
Not on an MSM, but on an elderly woman who came in, and I was like, I really think this is ringworm. And I will say for this patient is kind of pushing the border for me, but for an isolated area, 1 or 2 patches, I will almost always start with a topical antifungal. It will work most of the time. You're kind of doing things in parallel. For someone who has extensive lesions, who has lesions in the genitals, who's really kind of going crazy, I think that's when I start to think about a systemic agent here. And I would use terbinafine. But topical antifungals are really effective. The other thing I want to say is that the old school treatment for this, the pre-antifungal treatment for this, is actually gentian blue. And I was a Peace Corps volunteer in West Africa, and kids would be just running around covered in gentian blue. And I have to say, it's shockingly effective. It dyes the skin. People hate it. Don't get me wrong. And it dyes the entire floor that you're around, but it does work. And so if you're facing something where you're like, I'm really concerned about this, I think that we're going to get resistance, I can't get terbinafine for whatever reason, and we're having some trouble with people affording it, quite frankly, gentian blue, it's available at Whole Foods.
What aisle is it available in Whole Foods?
It's in the homeopathy aisle. So, you're telling people to go directly to this and don't touch anything else in the aisle. But...
That's awesome. All right. So we have gentian blue, possibly topical, and possibly terbinafine. Other thoughts from our other panelists?
I would say, thinking from the public health clinic perspective, we have a lot of folks coming in who don't have insurance or ways to get meds covered. So if it is, I agree, a localized 1 or 2 lesions here or there, topical antifungal is very reasonable place to start. But in addition, if you need a little time while you're trying to source the terbinafine, that can also be a reasonable option. But having more diffuse lesions like this person does, I would probably try the terbinafine as well.
All right. So this is actually why I wanted to highlight this case. Because actually with TM7 in particular, we don't have a lot of luck with topical treatment. So, in this case series from the group in Paris, some things worth highlighting is actually that they were able to do a disease investigation, and they were able to track 17 cases back to a single tantric masseur, 15 clients and 1 roommate, which really just highlights the sort of close physical contact nature of transmission of this particular type of trichophyton. And one of the reasons we're starting to see spread amongst men who have sex with men. What they learned from their experience was that oral terbinafine was really required in almost all cases. Topical therapy alone led to failure. And it's not just short-term use, which is what we often think about for these fungal infections. Some remain culture positive 3 to 4 weeks into terbinafine treatment, which really highlights just how long we really need to treat people for. And the fact that contagiousness can persist during incubation and treatment. The fact that people were 4 weeks into treatment still culture positive suggests they can still transmit, which really goes a little bit into how we need to counsel people about this particular disease. In terms of treatment, if it's TM7, it's usually susceptible to terbinafine. Itraconazoles are alternative. One of the biggest reasons to get a culture up front is if it becomes trichophyton endotheniae, it's often terbinafine resistant, and then itraconazole becomes our drug of choice. We generally need prolonged oral therapy, weeks to months, plus or minus topical antifungals, but topical antifungals alone are generally not enough. We want to avoid corticosteroid creams that people often get over the counter and do often before we see them. And we actually need to think about partner management. We've seen several people here who came in who then brought in their partners who had very similar lesions. And so we want to also think about partner management with STI-style contact tracing and treatment. And it's a great reminder that STIs are always emerging and we're always seeing new things that challenge the way we think about sexually transmitted infections and how we manage things that we used to think were really straightforward, like ringworm. Going back to our case, he was started on fluke empirically, but switched to terbinafine when he failed to improve over 2 weeks. His culture actually grew TM7, and he completed 8 weeks of terbinafine with resolution of his lesions. He is one of the people who brought in his partner who ended up treating as well for more mild lesions, but we treated the partner so that they wouldn't reinfect each other. And so this is just sort of a quick summary about dermatophytes, but we're now seeing dermatophytes with sexual transmission. It's circulating in MSM networks across Europe and the US. There'll actually be a National Network of Prevention Training Centers TM7 webinar in late January highlighting the Minnesota outbreak. And it really does have outbreak potential. And we've seen clusters linked to sexual contact. It has prolonged incubation, which really affects the transmission dynamics, and it can be contagious pre-symptomatic and during treatment. For TM7, we usually need to use terbinafine for a long course, 3 to 6 weeks minimum. And it really matters because we want to prevent recurrences and misdiagnosis, and we need some STI-style partner management, which we, on this call, are sort of the right people for. So I'll stop there and see if we had any questions about TM7 before we went on further. I'll just highlight that that they did put in the link to the dermatological STI manifestations talk in the chat.
I think, Jason, too, you set up for us we had a dermatologist come to our clinic and show us actually how to do the scrapings. So to implement that or have that kind of training in your clinic would be a great thing to try to do as this becomes more relevant to more places around the US.
That's a great point, because it's actually one of those things that's really easy when someone shows you. It feels kind of intimidating. It sounds kind of intimidating. And then they come and show you and you're like, oh, I can do that. And so I think that's really a fantastic idea to bring into other places as well. And hopefully your dermatologists are as friendly as ours and will come by and show you.
I do have a question for you, Jason, and the other panelists. How far is your lab or your laboratories able to go in terms of identification of the tinea species? And do you have to ever send out, and what's your reference lab for that?
Yeah, so we can usually do ITS sequencing, which can actually separate them out. If we end up with a mixed result, which we have had happen, we send it to the state lab, which for us is Wadsworth, same as you, which can do a better identification. But it can sometimes certainly be challenging to get the final identification on that, and sometimes needs to be sent out, which again, to me, highlights why we need to do this so early on, because it can be quite a while before we see that result, and we don't want to wait till someone's failing to try to figure it out.
I'll say we are not fancy in our clinic. We use LabCorp as a commercial
Yep.
lab. And so I would have to dig into LabCorp and then thinking about the state. I will plug University of Washington's microbiology lab, which is just a phenomenal reference lab. And if you call them, we'll walk you through. I mean, Christine and I both graduated there. We know those folks well. And I will say, but when I have my fellows call, when people call, it is a very helpful phone call with some very experienced microbiologists who can kind of help navigate you through that process if your state lab is not able to do it, or if you're using a commercial lab, like many of us are, even in the public health space, because of I don't know, living in 2025. So I think that using that and calling and finding out what you're doing beforehand is really critical. There are questions in the question and answer thing though. So someone's asking us what features may encourage you to do a scraping on the initial visit.
Yeah, so for me, to do a scraping initial visit is essentially more than a couple of lesions in different spots. If I see more than 1 or 2 lesions, and if, to be honest, these days, especially in New York City where we know we're seeing this, if I see genital lesions, I will generally send the scraping simply to get the identification, in case it's going to be something more complicated later. And then someone said, can you consider giving him something for pruritus so he doesn't spread the tinea while scratching? I have never thought about that. Have you guys done anything like that? That's an interesting question.
It's an occasion where go ahead, Dane.
No, I was going to say, I personally have not, but I've seen dermatologists prescribing a compounded combination of steroid and antifungal. Sorry, Gretchen, go ahead.
No, that's exactly what I was going to say. That's what our derm does, and it's very effective.
We have a little bit of a different question. How often are people seeing drug reactions with doxy-pep? I don't know if any of the 3 of you want to comment on that at all.
I haven't seen a single true drug reaction. A little bit of intolerance, GI upset that we typically see with doxy, but no true, certainly not a dermatologic reaction.
Yeah.
Same for us as well. Although sometimes I like to say our clinic sees more, quote, fixed drug eruptions than in other practice. But most of these are really not doxy reactions in terms of true allergy.
Yeah, we actually had our first that I think is in a true fixed drug eruption from doxy-pep relatively recently. With that said, we've started hundreds of people, like hundreds and hundreds of people on doxy-pep, and had our first one. So the rate is going to be well below 1% in our clinic. We're probably between 500 and 750 people started and have had one so far. So I think the rate is extremely low, but it is something that we do know happens with doxycycline, something we should be aware of and think about. But I think the rate is relatively low, extremely low. Okay. All right, why don't we go to the next case in the interest of time? So I'm going to do the next case before I turn it over to Natalie. The next case is Julie. She's a 30-year-old woman who presents to urgent care. She presents with 1 week of thin white vaginal discharge and vaginal itching. There's no pelvic pain, genital ulcers, or erythema or systemic symptoms. She has a prior history of bacterial vaginosis 2 months ago and thought this might be a recurrence. She's sexually active with 1 primary male partner, 1 new male sex partner, and she uses condoms consistently with a new partner only, not with her primary partner. And so with that, I'll ask sort of, what's your differential diagnosis and what type of workup would you do?
I can start on that one. Thin white vaginal discharge with some pruritus, with a history of BV, and sort of the person come in saying, I think I have BV. We know that recurrent BV is quite common, and that would be number 1 on the differential for me. She also has a new partner, so you would worry about bacterial STIs as an etiology as well. I would, depending on the clinic setting and whether or not a wet prep is available, might lead you to do different types of tests, but could start with doing a wet prep. that can help with the diagnosis of BV. You can also potentially see trichomonads if that were a concern as well. You could send either a vaginal or a cervical or a urine for gonorrhea and chlamydia. That would sort of be where I would start. And the wet prep would also show if yeast was a consideration as well.
Great. Other things you guys would think about, Gretchen?
The only thing I would add to that is, one, she doesn't talk about whether or not her partner got treated for her BV, her primary partner, and there's really compelling data that partner treatment prevents recurrence. And so I would be investigating whether that happened, whether that was prescribed. It's kind of a pain in the neck for the male partner, quite frankly, but it's very effective. The other thing is that I'm a huge believer in the vaginal pH. And so if you're going to do a pelvic, which this woman needs a pelvic, like, let's all be clear, this is not a self-collect swab situation. She needs a pelvic exam. You need to take a look and see what's going on. And the pH paper is cheap, effective, and probably one of the most sensitive things that we can do looking for BV. So even if you can't do a full wet prep in clinic, you don't have time, you don't have the microscopy, whatever, a pH above 6 is very diagnostic. It really changes your pretest probability, but I completely agree with Dr. DiMarco on turn differential.
Yeah, I agree with both of the panelists. So in our STI clinic, we would do a pelvic exam. We would look to see if there's evidence of cervicitis or PID on exam. And then definitely we do wet prep, and we can do a bedside pH as well as whiff test to get a pretty good diagnosis of what the vaginal discharge is right there during the clinic visit.
Fantastic.
Yeah. Just another plug for the pH paper. It's almost non-existent now in many of the outpatient primary care and OB clinics, and I think the STI clinics are some of the isolated places that still have it. And as Gretchen mentioned, it's very cheap, so it's a really nice thing to have as a diagnostic tool.
You can literally buy it at Home Depot. Like, I'm not kidding. You do not need to order the McKesson pH paper.
So far we've sent people to Home Depot and Whole Foods today. Everyone's getting their Christmas shopping done while, completing errands. All right. So sadly, this patient was not seen in our clinic. This was an outside clinic where they used some sort of lab-developed multiplex PCR that has the following items on it. I know, I see big sighs from the panelists, but this is how I feel when I get these calls as well. So the multiplex PCR panel comes back. GCCT was negative. TRIC was negative. BV was positive. MGen was positive. M. hominis, thankfully, is negative. Urea plasma is positive. So with all of these things that you now know, what type of treatment would you offer her? And I can go back to the slides. You can see all the things she had positive as you're thinking about what treatment you'd offer her. And please tell us what you're thinking as well.
Christine, you want to go for it?
Sure. So I would treat her BV. I think that's the most likely problem for her. I would get that treated and consider partner treatment as Gretchen described, since we have some data about that now. As far as treating MGen and urea plasma, I would be hesitant to do that. I don't know that it's causing her symptoms. I still haven't heard about a pelvic exam. I don't know if she has cervicitis or some deeper infection. But I would treat her BV. If she gets better with that and has no residual findings, I would not treat the other two infections.
I will say, in terms of her exam, the note says exam normal. It's unclear to me if a pelvic was completed or what parts of the exam were normal, but the exam says normal.
So MGen, so urea plasma can be a part of the normal vaginal microbiome. And so I feel very confident ignoring that. In certain cases, it requires treatment. The reason that we're all taking a deep breath and nobody really wants to talk about MGen is that people have very, very strong feelings about MGen. And there are people who very strongly feel that all MGen should be treated and that it should be a reportable STD, all the way through to people who are like, c'est la vie. And I think that Dr. Heumann is really trying to thread that needle because we see asymptomatic MGen not infrequently in women. It is like, this is a terrible analogy, but I'm going to make it anyway. It's kind of like group B strep. In a woman who's not pregnant, you're not particularly concerned about group B strep in the vagina. However, MGen can be a bad actor. It is associated with preterm labor. It is associated with early miscarriage, and it is associated with PID and acquisition of other STIs. What we don't know with particular certainty is in women who also have BV, is MGen a primary actor in their BV? And because it is a pain in the neck to treat, because it is poorly understood and the natural history of it, I think we can say is not fully elucidated, I would go for the low-hanging fruit, treat her BV, treat her partner. And then if that doesn't work, if she has persistent symptoms despite treatment of her BV, then I would start looking at her MGen.
I see a lot of nodding from the panelists. Natalie DiMarco, you came off mute?
I would agree with both Christine and Gretchen that I would treat the BV as well and wait for the others, reassess, afterwards if the person still has symptoms. But
Folks want to just have some clarification of what the treatment of the male partner should be.
That we have a slide on that coming up.
And then, Jason, do you have a slide on EPT? Because it's a state-to-state thing.
For MGen?
No, for BV.
We do not know. So not in this one. So we'll come, let's stick with this for 1 second, actually. So, we talked about what treatment we'd offer Julie. This slide really just highlights how common MGen is if you actually look at it, right? Prevalence can be as high as 10% in both men and women, which is one of the reasons we talk about it being a possible colonizer versus a bad actor in certain cases. And we really have to be convinced that people need to be treated for it. In this case, she got treatment for BV, and she also got treatment for MGen, with the standard MGen regimen of doxy followed by moxy. As I mentioned, I don't think that's what I would have done, as it sounds like many of the panelists probably would have not either, but that's what happened here. And then the next question is, would you have offered her partner treatment? And this is actually a poll for the audience for both MGen and BV, MGen, BV, or would not offer partner treatment. Did we see the results of it? It disappeared, but I didn't see the results.
Jason, it is not letting me share the results, but I will tell you the results. That 52% said yes for BV, 28% said yes for both MGen and BV.
Great. So panelists, what do you guys think?
I would offer that partner treatment for BV. We don't know a lot about this person's sexual history and their partners, but you might get a little bit more of that information before you jump into the partner treatment recommendation for them.
Yeah, I had mentioned doing the partner treatment before as well for BV, though I think it's also important to consider here, she's not the typical person from those studies. So those were monogamous partnerships, and she is having additional partnerships outside of her primary. So that's something to consider. I don't think you don't have to exclude her from this treatment, but she may not be the typical case that benefits from this, from what we know from the literature. So that's worth considering and discussing with her. And then the MGen, I wasn't big on treating her, so I probably wouldn't treat her partner either, unless I really thought she was symptomatic from MGen, in which case then I would treat her partner.
All right. And I think that's pretty accurate. We got a little bit more history after we got this case. And then we found out that, she'd only been with this new partner once, and she'd been with her primary partner for the prior episode of BV as well, which maybe supports a little bit more of her fitting into sort of that category. Because, you know, there's this recent New England Journal article that our speakers are all talking about that talked about high recurrence rates of BV with female-only treatment and how mountain evidence really suggests that sexual transmission via male partners contributes to recurrence. So there was this open label RCT with 164 couples randomized with a primary outcome of BV recurrence within 12 weeks. And found a pretty significant absolute risk difference between the two groups, and a longer time to recurrence in the partner treatment group, really supporting the idea of partner treatment for BV, especially when you have a primary partner or are monogamous and getting recurrent episodes. And so as Dr. Heumann was mentioning before, you know, this was a patient who, when we got further history, she'd essentially been primarily monogamous for the last year and had one episode with one new partner. So this was more likely coming from her primary partner. And so she did receive partner treatment. I'll just highlight MGen one more time because, you know, it does come up. I know Jacob talked about it yesterday during the STIs 102. But a reminder that we should be, for sex partners of symptomatic persons, should be tested and then treated if positive. And so that's the current recommendations around MGen for partners.
So not really expedited partner therapy, but really testing and then treating.
That's right.
Just to, and the treatment, I don't know, Dr. Newman, if you want to talk about, because you were describing how difficult it is for the partners, like what the medication would be for the partners.
So I actually think it's really interesting because BV is really a dysbiosis issue. It's not a true infection, it's a transmitted dysbiosis. And so what you have to do is you have to change the skin microbiome of the penis. And there were many studies of partner therapy for BV that were negative and didn't show anything. And they used either topical therapy or they used systemic therapy. The Step Up trial was the first trial that used both oral metronidazole and topical clindamycin applied to the skin of the penis, including retracting the foreskin in uncircumcised men and applying it to the actual glans penis. So you have to do, in a circumcised person, you're doing the full glans penis and shaft. In someone who's uncircumcised, you're retracting the foreskin, the glans penis, and the shaft. And I will say that we have a vaginitis clinic that's co-housed in our HIV clinic. It takes commitment on part of the male partner. They have to do it for 7 days. The clindamycin is available. It's about $40. Is its like kind of shelf price. It's not covered by a lot of insurance yet, and so you're really looking for the male partner often to lay out that $40. And so, as Dr. Heumann is saying, people who have a lot of casual partners, that's not likely to be as effective. And the best effect is in people whose partner really does adhere. In Michigan, we actually took this to the state. The state was very excited about doing EPT for BV. And we took it all the way through it went through our risk management and the Office of the Attorney General. And the determination was that because BV is not a reportable illness, it would not qualify for EPT. And so our solution has been to do a phone call visit. We do a telemedicine visit with the partner. We register them. We do a telemedicine visit so we can say we are their provider, and then we give them the treatment.
I think that makes a lot of sense.
Company, then you're good to go.
I think that makes a lot of sense because BV, I would suspect, is probably not available for EPT in any state currently, given how new that trial is. Most states allow it for gonorrhea, chlamydia, some just gonorrhea, chlamydia, some gonorrhea, chlamydia, trick. And some say whatever the CDC says, and they don't necessarily recommend EPT for BV yet. And so I think for EPT, that's a challenge. And I think the phone visit or doing a virtual visit is a really great way to be able to provide partner therapy. All right. So Julie comes back 4 weeks later. Her symptoms improved briefly, but now she has persistent dysuria. You revisit her history and she notes no sexual contact since her initial urgent care visit. The exam reveals some thin white vaginal discharge, no CMT, slightly erythematous cervix, and repeat testing with another panel is notable only for positive MGen. What would you offer Julie now? Sorry,
And
guys.
she's already been treated for MGen, is that correct?
She's already gotten treatment for MGen. She says that her symptoms improved briefly, but then worsened pretty quickly with persistent dysuria.
So first I would want to know what happened with her partners. Were they treated? Has she resumed sex with her primary or other partner?
Yeah, and she says she is not. So she says she's had no sexual contact since her initial visit at that urgent care. Yeah.
I
Yeah, why-
honestly, I know. This is tough because I think that, you know, are you doing, so the MGen is positive on her vaginal discharge, or is this a urine MGen?
This is the same vaginitis panel that actually happened previously.
And has she had a UA?
No,
I think that was my question. I didn't remember that she had dysuria in the beginning. But
she didn't actually really have dysuria at the beginning. She noticed it much more after the discharge improved. But now it's much worse than it was before.
so I think we're in the situation where I would probably make sure she doesn't have just a UTI, but also
Mhm.
thinking about whether or not she needs retreatment for MGen. And I can't remember if her partner got treated for MGen, as Dr. Heumann asked about.
He did not.
Mhm.
Yeah, and though that she'd not been sexually active with him again, but his
Right.
partner was not. Her partner was not treated. If you were going to retreat for MGen, how would you do it?
Good question. Um, I think it depends on what tests are available to you. There is, I believe, through LabCorp, there is a macrolide resistance assay, which is performed as a reflux to the Mycoplasma genitalium gnat. So if you wanted to do something like doxycycline to potentially azithromycin, that would be an option. We don't have a great idea of what the exact azithromycin resistance profile is in the US, but in other countries it's quite high for that organism, which is why we use the quinolone here as our first line. You could also think about doing a course of minocycline, and there are some reports of using high doses of tinidazole in combination with other drugs as well.
Yeah, I think that's pretty good coverage of sort of all of our options here. I wanted to highlight this because we're getting more and more referrals from community providers for MGen that's not improving on doxy followed by moxy. We do have some wide issues here in the US. There's no FDA-approved, widely available MGen resistance test. The one that we can do now from LabCorp looks for azithromycin only, but many clinicians don't have access to that if you don't have access to LabCorp. Rising macrolide resistance with high fluorocarbon resistance as well, and really limited alternative agents in the US. And we don't have an established alternative for people who fail doxy followed by moxley. The treatments we do have are the ones that Dr. DiMarco just laid out. The minocycline, you can do it for 14 days, or you can do it even longer. I've done it as long as 28 days before. In the 14-day study, there was a 67% cure rate. And there's a single case report of the tinidazole as well. And then there might be some future options with Geo or Zoli, but we really need a lot more data to understand whether those will be effective and in what way to use them. There are other options, though, available outside the US. So pristinamycin is used in lots of parts of the world except the United States. It's been shown in patients with macrolide-resistant MGen to have about a 75% cure rate, and that may be even higher if you did a doxy lead-in prior to the pristinamycin. And then citalfloxacin, which has been used widely in Japan, has as high as an 88% cure rate, although that was as initial treatment, and is another option as well. For this patient, when she came to me having failed treatment, we did macrolide testing and it was macrolide resistant. I was going to do minocycline, but then, she actually told me she was going to England for work the following day and that she was interested in going to France to get pristinamycin. So she actually did a 7-day course of doxy, which we started right away, followed by a 10-day course of pristinamycin with resolution of her symptoms. And then we recommended that both of her sex partners be tested for MGen, and one of them tested positive, and we did treat that partner empirically in the end. Do we have any other questions about this particular case before we move on to the next one? Was Trick tested? Trick was tested on the initial multiplex panel and was negative. And with that, I'm going to turn it over to Natalie, who's going to control the next case. Natalie, you still had to do the remote control at the top?
No.
You now should have control. I just gave it to you.
Okay.
And actually, Jason, there was a question that came in the chat, not
Okay.
the Q&A. So the question is there any data on accuracy of MGen testing through urine versus vaginal or urethral samples?
You mean a swab as opposed to urine? I would have to go look. Generally, we do see a small increase in sensitivity with swabs over urine, but I'd have to look. I don't know if any of our panelists know of a specific study that sort of characterizes what that difference would be, but I don't know off the top of my head. Okay.
Yeah, I don't have the exact numbers, but we generally accept either urine or a vaginal swab from a woman to test for this, with that preference for vaginal if we can.
Yeah, exactly.
Yeah.
Right. Jason, tell me again how I move this slide.
Just hit enter.
Oh, sorry.
Hit.
There we go. All right, so we're moving on to the next case. This is Travis. He's a 37-year-old male who follows with you for general primary care. 4 days ago, he presented urgently to the ophthalmologist with 1 week history of blurred vision. On exam, he had a vision in his left eye of 20/50, and he had panuveitis with a placoid macular lesions and focal outer retinal punctate lesions. They thought, and they told you that they thought it was consistent with syphilis. Our ophthalmologists are pretty good. And the lab workup was sent at the visit, and he was asked to have close follow-up. Today, he notes that his vision is unchanged. He feels otherwise well, no headache or hearing changes, no disequilibrium or eye discomfort. On exam, however, you note that he has mildly decreased visual acuity, and otherwise it's normal, including a normal, I don't know what that, a Euro exam is. Sorry. His past medical history will continue is that he has HIV. He was diagnosed 12 months prior. His CD4 count was 390, and it's now 629. His viral load is undetectable. He's on TAF, FTC, and bictegravir daily. He's on valacyclovir as well for a history of cold sores. He has a history of allergy to penicillin. He's not exactly sure, but it did require hospitalization. He has a remote history of gonorrhea, urethritis in the past, and his RPR was negative when he had his HIV diagnosis a year ago. He stopped having sex when he got diagnosed with HIV. That was about 6 months ago. After becoming undetectable, he started a relationship with a new partner. He uses condoms inconsistently. He works as a teacher. He lives alone and has 2 cats. We love the ID history. And he drinks 3 to 4 drinks a week. He has no tobacco or other substance use. The workup that you do in your clinical practice, you send a quantiferon, which is negative. You send toxo, which the IgG is positive, IgM negative, and RPR, which is negative. You note that his inflammatory markers are slightly elevated with the ESR, and his CRP is normal, and an serum ACE is pending. So I'm wondering, Gary, if our polls, or Jessica, if our polls are back up, but we want to know from the panelists and the audience, why is the RPR negative if you think this is syphilis? Remember what the ophthalmologist said.
And Natalie, sorry, the polls are not back up.
Okay. So in your head, think about it, or you can put it in the chat, and we could sort of relatively add up what the responses here. Do you think number 1, the infection is too early for seroconversion? Number 2, there's an alternative infection like toxo or HSV. Number 3, it's had a false negative syphilis serology due to HIV. Or number 4, we're seeing the prozone effect. I feel like I need some music. Do, 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 do. Everyone's had a moment to think about it.
And Natalie, I'm not sure if you can see the Q&A in the chat since you're
I
up right
can't.
now, but
Yeah.
Okay. All right. Well, so some people are saying number 4, the proton effect. Less people saying alternative infection. Somebody said false negative syphilis serology.
All right, let's have our panelists weigh in. What do you guys think is going on? Why, if the ophthalmologist said this is syphilis, does he have a RPR that's negative?
It's a great question, and I think how often you get it probably depends on what your laboratory uses in terms of the screening cascade for syphilis testing. So it seems like in this laboratory, they start with a non-treponemal test, like an RPR, and probably then reflex to an ELISA or some other TREP-specific test. So you can, with very high titer or high antibody level, have this prozone effect and end up having to ask the lab to dilute, to do serial dilutions to try to get a better handle on what you're dealing with. If you're thinking about ocular syphilis, the person would generally have positive syphilis testing, or RPR, I should say, by that point.
We have seen ocular syphilis too early for seroconversion. I will add that. Like it is hot, syphilis can do whatever it wants. It's like TB.
Yeah.
So, Dr. DiMarco is 100% right. The most likely answer here to me is the prozone effect. I would say, however, that we have seen in a couple of cases the infection too early for seroconversion. And I'm actually going to get on my soapbox here. This is a case almost identical to this, is why I do what I do. I was a resident and I had a young man come in having had an anonymous sexual encounter in Piedmont Park in Atlanta, blind. And he had lost his vision over the course of 2 weeks, and his RPR was negative, but he got sent in for ocular syphilis treatment. He was the prozone effect, as Dr. DiMarco was saying, and he was resistant to an HIV test the entire time. So it's interesting that this is an HIV positive individual who knows his status, but often we are seeing in places with uncontrolled HIV epidemics that ocular syphilis can be that first time that pushes someone who is very scared of HIV testing towards HIV testing. And so I have a lot of thoughts about this case.
Keep going if you want.
No. You're going to get to all of it, so I don't want to.
Okay. Well, similarly, I think that, having a right, the questions, at least he told you, or you were able to see that he had visual changes. But often I had a case similar to what you were saying, new diagnosis HIV. And I was like, hey, I love your glasses. And actually he was like, I just got them 3 months ago and I can't see now through them. So I was like, oh my goodness, go right now to the ophthalmologist. And sure enough, he had ocular syphilis. So you really have to have it on, high on your index of suspicion.
Yeah, something else I would wonder about for him is, has he ever had a treponemal test? So could this be a really old infection and he's only treponemal test positive and now his RPR is negative over time? That wasn't one of the choices, but something I would be thinking about.
Exactly. Well, if he had, usually I think when we're doing the workup for the primary HIV, the test would be done, or initial test for HIV entry into the clinic, we would do the HIV test. So agree, you need to know the timing and what it is. And this figure right here sort of talks about similarly the timing of the serology for HIV. We see that, as you guys were mentioning, it depends on what you're going to do. If you're going to use the treponemal specific test first or the non-treponemal test first. The RPR we know in early syphilis can be not detected. So there is that period of time in early syphilis where the treponemal specific test is actually better than the non-treponemal test. And it wanes over time, and it's what we use to follow the treatment. So it's important, obviously it's important to do as well. Oops, good. So he does end up having the diagnosis of syphilis uveitis in the setting of having HIV. And we do want to make sure that everyone has like a broad differential when you're looking at these cases. You know, they did talk about him having a cat, and toxo is one of the infections that he could have. And the ophthalmologists actually are quite good at detecting this. We know that the serology for the diagnosis is the accuracy, and it's generally reliable, but sometimes we might not have an accurate test. So it's really important to have that ocular exam. As you all mentioned, this is a figure that talks about the prozone effect, in which you have a false negative RPR due to mismatch between the patient's antibody and the antigen test. So if you have a lot of antibody, as you see here in the very right-hand figure, this is the prozone effect. So you don't get this lattice formation. And those dots that are all together, the clumping, is what you see on the Guthrie card, and it is subjective. And it's manually done. Somebody had asked, I think, in one of our Q&As before, like, can it be done automated? And I am not aware of that. As a panelist, anybody aware of that? No, I think it is still a manual test, and it's pretty subjective. And most microbiology clinics do the test for prozone, but some might not. So you definitely need to ask. So you call up your lab, of course, that's the thing that we always do in ID, and you ask them to repeat the RPR with diluted serum to check for prozone. Sadly, there isn't enough specimen left, which we've all been there. You're able to get labs again on the day when he comes to clinic. What testing would you send? So in this case, he's coming back. Would you send the RPR again? And I guess it depends on the timing, but you all can talk about what you would do and the timing of it. Would you do the reverse sequence syphilis testing? So starting with the treponema test, or such as an FTA. Would you at this time say that he needs to come in and get a lumbar puncture and look at his CSF and send a VDRL? Or would you ask the ophthalmologist to do a vitreous aspirate and test for treponema by a PCR? And I believe the polls are not still working. And so we'll have our audience just put things in the chat, and I will have Gary or Jessica let me know, or Jason, if you could see them, what people are saying.
I will just
Yeah,
add.
no problem.
I'll just add one thing, that a couple of years ago, they did actually approve, I don't know anyone who uses it, but the first automated RPR analysis machine. There actually is one that exists now. Again, I don't know of any lab that actually uses it, but I was actually talking about it with our lab the other day. So it does exist. I just don't know who's using it.
Wow, that's cool.
Yeah. Yeah.
Okay, so Natalie, we are seeing few responses saying number 2, one response saying number 3.
All right, panelists, help us out. What should we do? What should we send?
I can start maybe and others chime in. But I would, because we're talking about syphilis and we're talking about treating syphilis, I would repeat the RPR, because you sort of need a starting point to monitor your treatment success moving forward. If this is isolated ocular syphilis without any other concerns or abnormalities on the neurologic exam, can forego the lumbar puncture based on the more recent CDC guidance from 2021. Depending on what's available, you could certainly do the reverse sequence serology to see if that's positive, and you might get that result back before you get the RPR. So it could potentially impact how soon you might start treatment or the management, depending on the scenario. And I don't think we really need the vitreous aspirate if we have positive serologic tests. So it all sort of depends on your one or two test results.
Danny, we have a question in the Q&A. It's not up there, but do you think there'd be any benefit in doing a VDRL? Does the prozone effect also occur with the VDRL test?
It's a great question. I'm not sure that a serum VDRL would be helpful here, and I don't know a lot of labs that have it available when it's not on the CSF, but in other countries, they actually use the VDRL instead of the RPR as their non-trap serum test. I do think, though, that you can still see the prozone with the VDRL. You can see it with other antigen tests and antibody tests as well, like Cryptococcus, for example. You can see the prozone as well. So.
Anybody else?
I would do the reverse sequence serology next, and then hopefully that would be positive and then trigger your reflex to your RPR. Maybe it's positive by now too. But I agree, no need for an LP or vitriol aspirate in the scenario.
Vitreous aspirate is insanely low sensitivity. Like, I do not know that I have a clinical scenario that I can consider where I would say, yes, T-pallid and PCSR in this vitreous aspirate. I agree that I would do 1 and 2 in parallel, honestly.
Perfect.
But I wouldn't be testing him right now. I would be treating him.
You'd be like, get you admitted to the hospital.
I would, because you can reverse the vision damage if you catch it. And if you spend too long diagnosing this, where you have, this is in large part a clinical diagnosis, even in someone who has RPR positive syphilis. If his RPR was positive, we would all treat him, right? And so absent this, we have a high clinical index of suspicion here. And the thing that I say to my trainees all the time is nobody ever died of too much penicillin. Nobody ever died of too much penicillin. And we can talk about his allergy, and I'm happy to discuss this. And it's not a small thing to do, but losing your vision is not small either.
Agree. I feel like syphilis, somebody with vision loss, and you're considering syphilis, is also similar to herpes in pediatrics. If you're thinking about it, just treat it and then figure it out over the course of the next couple of days. So this is a nice paper that Jacob actually found that looked at ocular syphilis with negative or non-reactive RPRs. And positive treponemal serologies. It was a retrospective study. They looked at 115 patients up at the Mass Eye and Ear, and they found that 22% had a non-reactive RPR with 2 reactive treponemal tests. So this, as we mentioned before, this scenario does happen. And it can happen, as we've talked about, I think in our previous discussions, this ocular syphilis can happen over any stage of syphilis. So you absolutely have to think about this when you're considering syphilis, any stage of syphilis. So in general, people with low titers or non-reactive RPRs in this study were older, they were HIV negative, and they were less likely to have severe ocular disease. But a significant portion of people with ocular syphilis who have a negative RPR, though, are more likely to have severe cases. So it is something that we have to think about. And now there's a review that shows that it can occur with a negative RPR. Unfortunately, we are stuck with serum in this case. We just want to remind everyone, as everyone mentioned, that LP is not necessary if you have isolated ocular or otic syphilis, because you're going to treat with IV therapy. And while PCR tests are promising for the diagnosis in early syphilis, like if you have a chancre, for example, it's not really commercially available yet, and there is no data on ocular fluid. Oops, I keep doing that. Apologies, everyone. So here's some new results for him. This time you send the reverse algorithm. The test is positive, and his RPR now is 1 to 256. When you start, and then you start discussing treatment, and he reminds you that he has a penicillin allergy. This happened to me the other day too, when somebody was like, oh, should I get this cellulitis treated? I'm like, no problem. We'll just put you on some Augmentin. And then just as I was prescribing, I was like, but do you have allergies? And they're like, oh yeah, penicillin, cephalosporin, and Bactrim. So I think we have to remember to ask that question when we are discussing therapy. So what would you guys do in terms of treatment? What would you recommend? Would you recommend hospitalization for penicillin desensitization, followed by 24 million units every 24 hours, IV? Would you recommend doxy, 200 milligrams BID for 28 days, ceftriaxone, 2 grams daily for 10 to 14 days, or procaine penicillin G IM daily with oral probenecin for 10 to 14 days?
I am old school. I'm really old school about this. And so I would take him in and I would desensitize him and I would use penicillin G. I think that if he declines that, you can have a discussion about alternatives, but I really believe in offering the standard of care. Now, I accept that the standard of care is circa 1945 and that doxycycline um, would probably be effective in this case. And I would still desensitize him, to be brutally honest. I think it's vision is big. It's really, really, really big. And I think that there's a question, do we think it's a true allergy? If you've been hospitalized as a child, I'm willing to treat that as a true allergy, bring you into the ICU. It's a couple hours away you go with your day, but I'm personally not comfortable with offering upfront alternative treatment. If there's reasons why he can't do it, we can discuss that, but I'm a number one as my first option.
How about the rest of you, Dr. Heumann?
Yep, I would also do number one. I would try to clarify his penicillin allergy because sometimes we find out they don't even need the desensitization. They're just good to go with the IV penicillin if we find out it's not a true allergy. But yes, my preference would be IV penicillin for the course.
Yep, I would agree with the others. In the pre-COVID days, we could get this done outpatient and somebody could get a PICC line one day but that doesn't happen anymore. It's just not possible. And so hospital admission, at least for PICC line placement and sort of getting all the IV antibiotics arranged, is usually needed for a few days.
Can I play devil's advocate and ask what you guys would pick if there were no ICU beds available, which to us happens all the time? It could be several days for an ICU bed. What would you do in the interim while waiting for that?
That's why God gave you doxycycline.
Would you do doxy over ceftriaxone?
I probably would, because I don't think that there's evidence that ceftriaxone is superior to doxycycline, and it is certainly less of a pain in the neck for this guy.
And the cross-reactivity, though, just to think about too, you can give it ceftriaxone even if somebody says that they have a penicillin allergy. But although, as you mentioned, he's got hospitalized for his pen allergy, so like, is he going to be in that 10%? Excellent. So the CDC does recommend penicillin as the primary therapy, as we've all mentioned. IM procaine actually no longer exists. And although it's still in the guidelines and people ask us, oh, it's still in the guidelines, we're like, yes, because the guidelines are from 2021 and they have to be updated. So hopefully the guidelines will become a live document and we'll be able to do that on a regular basis. Doxy is plausible. We know it does penetrate the CNS. We use it for Lyme disease, CNS Lyme, another spirochete. So it is possible, although the data is limited. And we are seeing some studies now with syphilis. We just had the 1 versus 3 study done by, for early syphilis. So maybe people are going to update those 1945 studies and do this one. We'll see. There is some data on ceftriaxone, but folks disagree. There was a retrospective study that suggests that ceftriaxone is equivalent or superior to IV penicillin, but there's a lot of limitations in that study. But there's no randomized clinical trial that's been available yet for that. So really for neurosyphilis, ocular, otic syphilis, so that we don't have permanent loss of vision or hearing, the recommendation is to do IV penicillin. And I think that is it for this case and syphilis. Any other comments from our panelists or from Dr. Zucker?
We just got a question about how does diluting the RPR to rule out the prozone effect change your interpretation of a fourfold decrease to show effective treatment? I don't know if anyone wants to answer that question, but just make sure we get through all the questions we are answered.
I don't think it would change my interpretation. So whatever the highest titer you get to in your dilutions for your prozone. So once you get to your highest titer, watch that fall down fourfold over the appropriate timeline.
I agree. Generally, when you get these really high titers, they drop way more than fourfold after treatment. So I don't think it'll be a problem to interpret it because it's the prozone effect is because the titer is so high that even if you dilute it out, you're still going to get a very high titer number that if effectively treated, you'd expect would drop down.
And labs do, not that this is directly related to the question, but since it is a subjective test, you might have your titer be different in different labs. I think somebody did ask that question. They might be off by, you know, twofold or something like that. I don't know if you all have experienced that as well.
Yeah.
That's pretty common for us. We try to get people to get their follow-ups at the same laboratory that they had their initial whenever that's possible. You can also run samples in parallel depending on how far a lab, how long a lab saves their specimens and banks them. So if you're looking to compare an RPR titer and make sure it wasn't interpreter variability, but it's truly different, you can ask labs to sort of get that older sample and run it at the same time as your current sample.
Excellent point. All right, should we move on?
I think we're going to take a break now.
Yeah, and actually, there's one more question that came up separately. It was regarding syphilis, and it says, we see a significant difference in RPR titers with different labs. Are some labs doing RPRs automatically and not by hand?
I think this is that inter-rater reliability issue because what they're doing is they're literally pipetting it out and looking at a card to see, oh, does this have speckles? Does this not have speckles? And so what we saw at our, I'm going to just throw my organization under the bus right here, at our safety net hospital is that we, in the course of COVID, we had massive turnover of our microbiology techs, and they were less good when they came back. And so everybody's titers went down because the techs were less sensitive in reading them. And so you can see that. I think this is part of what we build in when we talk about a fourfold increase, is that the ideal is that you're looking at nothing more than a 1 dilution or twofold difference in inter-rater reliability. And I think we need to accept that there is variability. RPR is also something where techs get good the longer they do it. And so you can see this when you're having a lot of turnover, like we are in all of entry-level medicine right now.
And I think as Dr. Zucker found, also we address whether it's automated or manually done. For the most part, it's a manual test, but as he mentioned, there might be a machine out there that is automating it. But it's our experience that that's not typically used at most facilities. Not yet.
Okay, great. There were no additional questions. So we are actually going to take a break right now. We'll take a break until 11:10 and then come back for a few more cases.
Great, everyone. Welcome back. Hope everyone got some beverage and you're ready to go again. A little energy. So this is Jasmine. Our next case she is a 24-year-old bisexual female who presents to her OB with painful vaginal lesions. They're so painful she is unable to put on her pants. On exam, they look like herpes. Okay. So obviously the left-hand picture is not her, but it could look like that. The lesions can also look like what you see on the right. And we want to just remind everyone, probably our panelists will discuss this a little bit, that there's a huge differential for these ulcerative lesions. It could be syphilis, herpes, mpox, LGV, chancroid, a little bit more uncommon, or granuloma inguinale. So you have to consider all of these. Obviously, herpes and syphilis are top, as well as mpox. It's really unique, herpes, in terms of being obviously super painful. Mostly there are group lesions, but it can be quite variable in a lot of people, and can present differently on different skin types and depending on the location of where the lesions are. And in addition, we have very often had this complaint that I can't urinate, so having urinary retention, and also, really every single thing they put on is quite painful. So we want to do a poll for everybody to keep it interesting. What should we do for Jasmine? Should we tell her to come back if, it's right in the middle of everything now. Tell her to come back if the rash recurs so that we can evaluate and send testing at that time. Should we send HSV 1 and 2 IgG, so blood, serum? Should we prescribe valacyclovir, 500 milligrams twice a day for 3 days, to be taken at the first symptom of the rash? Should we send a lesional swab for HSV 1/2 PCR? Or should we prescribe valacyclovir 1 gram daily to prevent future recurrences? A lot of mixed questions in here. Testing, treatment. I think this is a quite common. All right, just let me know when we got some answers going.
And just FYI, we are having answers coming in. Some folks are unable to submit their answers via poll. If that's your experience, feel free to put your answer option in the chat.
Great. So we did close the poll, but you can keep answering if you want. 57% say send a PCR. Yay. 30% say prescribe valacyclovir 500 twice a day for 3 days to be taken at the first symptom of a rash. A few people wanted to send serology. What do our panelists think?
I'm with the group here on sending a lesion swab, so that you can tell right there if that ulcer that you're seeing in front of you is due to herpes and whether or not it's herpes 1 or 2.
I completely agree. I think that there is an argument to send serology concurrently. Anna Wald certainly believes that when someone's presenting with herpes for the first time, we should send serologies to determine if this is their first outbreak or if they've been exposed in the past. I remain debatably convinced about the necessity of doing that and tend not to do it. But I would also say that sending a lesion swab for HSV 1 and HSV 2 is necessary, but not sufficient in this case. When we look at people who present with genital ulcer disease, we see when we look at nationwide claims data that they are often not tested for other STIs and that even their lesion testing is insufficient. And so depending on what is going on in your area and how convincing these lesions are, I certainly would be also sending mpox testing, and I would be sending VZV testing potentially. I would also test her for all the other STIs.
Excellent.
Yeah, I would add a plug for syphilis testing as well. In some areas of New York State, we've had a couple of clusters of syphilis infections where they had multiple painful ulcerative lesions that appeared very similar to herpes. And of course, you can't rely 100% on your serologic testing at that point. So if you have access to dark field, or perhaps you've done your herpes testing, it's unrevealing, and you're working through the other diagnoses at that point, you might consider treatment, or you might consider retesting down the road.
To echo what she was saying, there was data out of the 70s back when people were doing a lot more visual diagnosis and we didn't have PCR. And the best STD doctors at the time in the 70s were 50% accurate in determining HSV from syphilis
Mm,
on their clinical exam alone. So we,
yeah.
guys, do the testing.
There's also that recent paper out of Australia that suggested that about 10% of cases of primary syphilis would be missed if you did serological testing alone, just sort of highlighting the importance of doing additional testing, not just relying on serological testing, especially in cases where you have an active lesion in front of you.
Perfect. So, as everyone mentioned, virologic testings of the lesions are really important. Obviously, the PCR would be the test that we want to do. It is FDA cleared. And the importance, too, for counseling purposes, it's important to know if it's HSV1 or HSV2. We are seeing much more HSV1 in the genital region now compared to HSV2, although obviously that is the more likely type to be present in the genital region. Culture can be done. You might need to do it if you're thinking about resistance, but a lot of centers and a lot of sites don't have the ability to do this anymore. So there are, as we were mentioning, times when serology might be useful. So, if somebody has recurrent or atypical lesions, if somebody has a partner who's positive for herpes, but it's generally not recommended to send serology. It is recommended that you do a two-step testing, and really you need to have the EIA with a confirmation test, like a Western blot. This is kind of difficult to do. I recently had somebody who had a Quest test sent where they had this two-step, and it was actually really difficult to interpret. I had to call them and say, hey, like, is this positive or negative? And they were like, yeah, actually, it's negative at the Western, but, blah, blah, blah. So I think it is a complicated situation. And I did talk to somebody at over in Seattle to sort of discuss this as well. IgM testing is not recommended. So what about her course? So we already mentioned, it looks like herpes. The testing was done and it was PCR positive for HSV2. The HSV1 positive was also this is interesting. PCR was positive, and she has both, I guess, in this case. She was started on valacyclovir, 1 gram twice a day for 10 days with resolution of her symptoms. 1 month later, she returns with recurrent painful lesions. What should we do for her now? Dr. Heumann, you're so quiet. Go ahead.
The first thing you do is sympathize. This just sucks. For most people, they have an initial outbreak of herpes. Many, many people, I don't know the statistics off the top of my head, never go on to have another outbreak. And that's certainly what you hope for someone with their first outbreak, is this is kind of, they're positive, but they never have another outbreak. When people have recurrent outbreaks, it really drives a lot of shame. And I think that's something that for those of us who deal with things like HIV and syphilis all day, we forget that herpes is an incredibly stigmatized disease. I've had people sobbing in my office for like untold minutes about a herpes diagnosis. And I think it's very easy for those of us in the STI world to be like, yeah, it's herpes, whatever, move on with your day. Most people don't move on with their day. And so that's a really important piece of management, is how you're going to counsel her about her partners and what are you going to do. Obviously, you're going to retreat her for this. I think you're gonna, you've done all of your testing, you've tested her for everything else appropriately. I do think it's worthwhile re-swabbing at the first recurrence to make sure that you're not missing something, but in subsequent recurrences, I do not re-swab. So I give first recurrence, I'll swab again, just to make sure, and then people get used to it. And I think the debate is really about treatment and suppressive therapy versus episodic therapy for her now.
Anybody else? Go ahead, Christine.
Yeah, I would agree. Oh, go ahead.
You can go ahead, Daniela.
It's
Okay.
you, Christine.
Okay. I was just going to say, I do not routinely re-swab after I've made the diagnosis. I would just treat clinically, but there's different practice there. And then as far as whether I would do episodic treatment or ongoing prophylaxis, it's usually a shared decision making with the patient because it can be quite variable. And then also what's going on with their partner. Does their partner also have herpes or not? Are they trying to reduce shedding and transmission to the partner? That's part of the conversation as well. So I do a lot of shared decision making in this scenario.
Similar to Christine, I have a very very similar approach. We do sometimes, particularly for HSV2, when somebody's had multiple episodes and we pursue suppression, we talk about the possibility of trying to stop that after a year or two and seeing how things go after that. But from the transmission standpoint as well, many people feel much more comfortable being on some form of suppression when they're having once they've had a couple of episodes. I guess I did want to go back to her initial episode just to mention, generally speaking, when somebody has an exam that looks classically like HSV, you also don't have to wait to start treatment to get that test result. So we didn't say that before, but we would go ahead and treat empirically with valacyclovir or acyclovir, whatever is available.
Great point. I often too, like at the first diagnosis, put in that extra refill and tell them if it comes back, then do you have it there? Because I think that is also the stress that people have. Like, what if it comes back? What if you're not around? What if it's the weekend and I can't reach you? Like, I think it's important to for them to have access to medications. There's no point in suffering.
Can I ask you guys, we've seen variable practice in our area around people prescribing things like topical lidocaine for the actual just pain management of it because it is so painful. I'm curious what you all do.
I have not used topical lidocaine.
Yeah, I have not, and I don't think anyone in our ID clinic or our STI clinic does either.
I do discuss supportive care, Tylenol, NSAIDs, that kind of thing, but nothing topical.
I think, yeah, that's been my experience as well. I do talk about, I think sometimes it's having them, I don't want any complications from the herpes, especially if it's extensive in the genital region. So having them like urinate in a sitz bath or something like that, I think is very, is important as well.
I guess I should say, a couple patients have told me in the past that they've used, if they have an anorectal outbreak, they've used a topical herpes, a topical hemorrhoid cream
Oh.
that contains lidocaine occasionally for that, but I've not personally prescribed it.
Neither have I. I've had a couple of people come through with it though, and I thought it was really interesting. Jack Sobel wants me to mention Epsom salt sitz baths here, which was the pre-acyclovir treatment for herpes. Again, available at the grocery store, and it can be quite symptomatically relieving, apparently.
So Kroger's this time?
Kroger, yep.
Excellent.
You know, I'd not used topical lidocaine for herpes, but it's a really great thought. I mean, we did it a lot for Mpox, right? For rectal
Yeah.
Mpox, we did a lot of topical lidocaine, and there's really no reason we couldn't use it in other instances where it made sense. Just the
Yeah.
swabbing thing that people were talking about before, you know, I had traditionally not re-swabbed, but in the era of Mpox, I've done a lot more re-swabbing just because I feel like the differential is now less clear than it ever was. Because Mpox can look so much like HSV, and I've been fooled so many times that I do tend to be a little bit more aggressive about repeating testing now, just because I feel like my differential is wider than it was before.
Jackie's asking about Vaseline. I don't use Vaseline. I do recommend Boudreaux's butt paste because I trained in the South. And you want the red tube, not the green tube. The green tube is some hippie shit that you don't need. The other thing that you can use is triple paste.
I love triple paste.
I know, right?
So for her treatment options, for first episodes, recommended acyclovir 400 3 times a day. You can see the list here. It kind of depends on your insurance, your tolerability. I've had some folks not tolerate valacyclovir, who then tolerate acyclovir. So I think it kind of depends on the person. It is way easier to do twice a day, I think, than even 3 times a day. And I've seen people come in with acyclovir 5 times a day, and I'm like, who is even doing that? Like, yes, like that is how sometimes it's written, but reality. You can extend the course, of course, beyond the 10 days if they don't improve. So as mentioned before, there are these 2 scenarios, either episodic treatment or suppressive therapy. Again, shared decision making that we've discussed as well. Really, it's the preventing transmission is a big part of it, and as we also mentioned, and partners feeling okay with their sexual practices with others, because sometimes it's difficult to know when you're shedding, right? You can shed before you even have the lesions appear. Here again is a list, and this is available on the CDC guidelines, the different dosing options for suppressive versus intermittent therapy. Anybody have any comments on what they feel they've used or what is better than others? I have to say, I haven't really used famciclovir much myself.
Yeah, I prefer to prescribe valacyclovir, often for ease of dosing, but we get acyclovir very cheap at our STD clinic, so we do give that one out because we can afford it.
Yeah, exactly. And in immunosuppressed patients, you're probably going to have to increase the dose or increase the duration, but that could also be variable depending on how their immunosuppression is, of course. So in terms of preventing transmission, we did mention that daily valacyclovir lowers the risk of HSV2 transmission. There are studies showing that in HIV negative people who have symptomatic genital lesions. Condoms also can decrease, but we know that they're not 100% effective. There is data also on male circumcision. We really want to caution about the transmission of HSV during pregnancy. We've had some people with new coupling partners and get HSV either at term or near term, and it does have significant consequences for the newborn. And when pregnant women, it's really important to begin suppressive therapy at 36 weeks. And I find our OBs are incredibly good about this, but you also want to make sure if you have a patient who has HSV, that when they do the delivery, that they're noting whether there are any lesions there or not, because it does change whether you're going to do, delivery by C-section or vaginal, for example.
Can I just go through a couple questions during the Q&A now before we move on?
Sure.
So you were talking a little bit about counseling before, but somebody said, I find it difficult to counsel patients on the risk of asymptomatic spread of HSV, even with suppressive therapy. Do you guys have any recommendations on how you counsel patients about the risk of asymptomatic spread? I know it's a hard question, but I think it's important because it's something our patients do ask about a lot.
Yeah, it's really tough because it's something, because it is so stigmatized, right? And I don't want to say for no reason, but like, of all of the STIs, talk about the largest delta between actual risk to health and life and versus stigma. And so I think that the thing that I tell people is that many people have herpes who have never had an outbreak and who have never known that they have an outbreak and who have no real sense that they could be transmitting herpes. And they're not telling their partners at all, ever, because they have no idea. And so I use a similar paradigm that I use when I talk to patients who are going to be who are HIV positive and are consistently undetectable. If you are having a one-night stand, it's probably not worth your time to tell someone that you are herpes positive if you are not having any symptoms and you are in between outbreaks. If you're going to be entering a long-term relationship with someone, you never want this to be the thing that breaks you up because someone feels betrayed. And so I have people kind of I kind of break it up that way. If this is a long-term relationship, if this is someone you're going to be having ongoing sex with, you're going to want to tell them, because if they're going to reject you for that, they were going to reject you for something else. And it's hard and it hurts and it never stops being awful. But thank you for the clarity. Moving on with my life. You are not the person for me and you never were going to be. If you're having a one-night stand and you are asymptomatic completely, whether or not you're on suppression, I personally tell people that they can choose whether or not they want to divulge that.
I think it is hard to bring that up. I think too, with time, especially as you get, years post-diagnosis, the rates of recurrences decrease over time. So that's something to look forward to. But I think it is having that in your head, just having over the last 6 months talked to a recently college graduate who was like, this is the end of my sex life and I'm never going to have children. I think I can't ever have a relationship again. I think it is the stress of that is something that people have to really work through. It's not an easy thing. Are there other, Jason?
Yeah, a couple other questions, or suggestion. Someone mentioned the possibility of Vaseline on the lesion so urine doesn't burn so much. I hadn't thought about that. I don't know if anyone's tried that, but it seems like a reasonable, safe solution if it works.
It's too thin.
Too thin, is that the problem?
That's why you have to use butt paste or triple paste.
Got it. Okay. Someone who said that they've used topical lidocaine in clinic, especially in patients with an outbreak in a pelvic exam. And I think that we talked a little bit about the idea of topical lidocaine being a good idea. Somebody mentioned that some teens can't swallow the 1 gram of Val because it's too large, which is a problem. And so acyclovir may be used simply because it's smaller and people can swallow it, which I think is a very reasonable approach. Patient partner with HSV2 using condoms and prophylaxis. She has never had lesions. Is it not of value to do serology for the patient? So I guess what they're saying is that the patient's partner has HSV2. They're using condoms and that the person who does not know if they have HSV is taking prophylaxis and has never had lesions. Should we be doing serology on that patient? Because I guess if they were HSV2 positive, maybe they wouldn't need to take prophylaxis.
Yeah, I think I would have that conversation with them. It could be useful if they both have HSV2 and they're monogamous and they're not having symptoms. Maybe they don't want to be on suppressive therapy. But that involves talking with both of the partners, and sometimes that can be complicated too.
Yeah, it would help too to know that you can get the confirmatory assay, which is not as widely available. Because when you can only get the first, you can potentially create more concern if or when relationships change.
Yeah. Great. We have one other question that's a little bit different than our other questions, but has anyone thought about there's concerning data regarding HSV being a risk factor for dementia? And has anyone thought about that when deciding whether or not to provide the suppressive treatment?
I have not.
Yeah, I mean, I can say that I've looked at that data a little bit, and I just don't think we have enough data for that to be the reason to put someone on suppressive treatment. Anytime we make a decision about whether to start someone on medication, we have to weigh the risks and benefits. And I just don't think that the data so far supports there being a significant benefit when it comes to dementia for HSV. We might learn more in the future, and that might change. I think right now, I don't think we have enough data for that. I don't know if anyone disagrees. Okay.
Well, extrapolating from, wasn't there a recent article on giving the zoster vaccine having, limiting reactivation with zoster and that being significantly associated with decreasing the risk for dementia? So if it's a similar herpes virus, but that's really extrapolating.
And I think we're learning a lot more about herpes viruses, right? We've seen all the
Yeah.
EBV data recently about MS and other things and autoimmune diseases. And so I think before we, know what the right thing to do is, we just need to learn a lot more. And I think people are looking into it.
I
Yeah.
also think that we need to be cautious here, though, when we're talking about HSV versus other herpes
Yep.
viruses.
Mhm.
HSV is not systemically distributed. It is
Yep.
localized to the place where you
Correct.
have the outbreak.
Yep.
And so that is a fundamental difference between HSV 1 and 2 and VZV, EBV, CMV, fill in your HSV 6, my personal bugaboo. But, you know, they're all the same and they are not all the same.
Yep. And I think that's another reason that we shouldn't necessarily be
Mhm.
counting things until we have more data and understand it. I think that's totally right.
Right. I think stop drinking Diet Coke if you're that concerned.
Please don't say things like that to me.
You know, listen.
I can't survive like that.
Uh,
Someone asked quickly just about, can you speak more about having screening when requested? And I think that's actually a really
Mm.
good question. You know, patients often come in and say, I want to be tested for herpes. I don't have any lesions right now. How do you guys handle that? Because it's certainly a very common occurrence in our clinic.
or they test me for everything.
We don't do it as a matter of course.
What do you tell people though as to why?
I just told them that a lot of people have been exposed. It doesn't give them any information that they can take action on. And that if they were to develop a lesion, we would treat it at that point. But at this point, all it's going to do is make them worry. And so we're not going to give them data that they can't incorporate into their life. Also, their insurance won't cover it.
Yeah, we also do not offer the serology at our STD clinic. And then if we are explaining, that's the same thing. You know, based on the results, I wouldn't be able to tell you if it was, you know, at the mouth or the genitals and when that exposure was and what it means for your future. It's really just better if we handle symptoms if they come up and test then.
The same for us as well.
And same for us here, but I think it's important to say it because I know that this is a question that's been asked a couple times so far, so for sure.
It's absolutely important. I mean, just to give a real world example, I had a 19-year-old college student who only had sex with the same person for the last 6 years, whose OB sent HSV serology and it came up positive. And that was the whole like couldn't get the follow-up Western blot, couldn't decide what it was, like, and she didn't even have lesions. She had vaginal dish, she had BV. So it was like, why?
I think this is where the fact that we're now getting oral labial HSV2 and genital HSV1 really serves to help us, right? Like, first of all, genital HSV1 is a success for the feminist movement. I just want that documented. Winning. Secondly, the fact that now you can't say that one of them is sexually transmitted and the other was transmitted when you were 14 and you kissed someone who was about to get a cold sore helps in that situation in particular, because you want muddy water. Like, just let the water be super muddy.
So we'll finish up with Jasmine. She was treated for 7 days. She chooses to go on suppression 1 gram daily. Several years later, she comes back to your office and lets you know that she's 24 weeks pregnant. She already established care with an OBGYN at another practice and is getting all recommended prenatal care. She hasn't had any recurrences of her genital herpes in the past 2 years. On further questioning, she realizes she forgot to tell her OBGYN about the herpes since it was so long ago. What needs to happen for Jasmine besides telling her OB about the HSV? Should she start suppressive valacyclovir now? Should she tell her to expect a C-section delivery? Tell her she'll need to start suppressive valacyclovir at 36 weeks. Make sure that she has the valacyclovir you originally prescribed and tell her to take it only if she develops symptoms. No need for any treatment since she's never had any recurrences. We touched on this a little bit already. And sorry, you are forced to make a single choice. All right, majority of people say, tell her she'll need to start suppressive valacyclovir at 36 weeks. Woohoo! Folks are listening. Love it. There's a couple smattering of other answers, but panelists, what do you guys think? Some nods. Yes, do it. All right. And as we mentioned, she doesn't need to do a C-section if there's no lesions at the time of delivery. I don't know that I would trust meds that are 2 years old that are in your medicine cabinet, although I've been known to do that. I would not recommend it for my patients. All right. So with Jasmine's consent, you share her HSV-2 diagnosis, treatment history with the OB. She self-monitors for symptoms suggestive of recurrence, but remains asymptomatic. She starts suppressive therapy at 36 weeks and delivers vaginally without incident. So just some takeaway points for everyone. When possible, HSV diagnosis should be confirmed by a PCR at the active lesion. HSV-1 is increasingly common cause of genital lesions, especially among younger folks, but typically causes fewer outbreaks and less shedding. HSV-2 causes more frequent outbreaks and increases the risk of HIV transmission. Serology may help support the diagnosis with or without active lesions, but is not conclusive. All patients with the first episode of HSV should get antiviral treatment, and subsequent outbreaks can be treated with episodic or suppressive therapy with shared decision-making, as we've mentioned. Suppressive therapy typically is used for those who have frequent outbreaks. Suppressive therapy can reduce outbreak frequency in all patients and reduces the chances of HSV-2 transmission among people without HSV. That's in the literature.
We do have a couple more questions on this one.
You're ready.
Sure. Prenatal patients in serology, any thoughts? Would you be more likely to do serology, less likely to do serology, the same likelihood to do serology? Would you ever do serology in a pregnant person?
Who doesn't have any history of lesions?
They just say in general, so I'm just asking in general.
Yeah, I was going to say if they had a history of lesions that were consistent with herpes, then possibly. But I don't think I would do it if they had no history of lesions. Similar to our discussion on using it as a screening tool.
I think it could get very complicated if we routinely screened pregnant women for this and we didn't know if we were finding herpes that were previously at their mouth or genitals, and what does this mean for the delivery and lifelong. And
the one thing I will say, and this is my pediatric hat, and Dr. Me is probably thinking the same thing, is that we do want serology in patients with a first episode of HSV near delivery. So if late in their course they have it's the first time they've ever noticed a lesion, we don't actually know whether that's truly primary herpes or just reactivation that they hadn't noticed before. And that actually impacts how we treat the baby. So the one thing I do encourage people to think about is getting serology. The one time I actually recommend serology is late in pregnancy, 32 weeks plus, if they have a lesion, to get serology because it may help us with the baby. Which it goes a little bit to the next question. If she became high risk for early delivery, would you start earlier?
Yes. Is the short answer to that.
Yep.
Yeah. Valacyclovir is safe in pregnancy. There's no downside, and you really want the valacyclovir on board several weeks before delivery. What I'm interested in here, as someone who has had a baby in the last several years, is that the guidance on when people deliver is changing. And so I would not be opposed. Most people are getting induced now between 39 and 40 weeks instead of letting babies cook forever. Turns out we were over baking them. And so they're pulling it earlier. And so this might be an argument similar to that, to start it at 34 or 35 weeks.
I agree. And it's one of the reasons that, if people have lesions late in pregnancy, even if it's 31, 32 weeks, I always encourage them to send serology because they may come earlier. So I certainly think if people are high risk or we suspect they may deliver early, to start them earlier makes sense.
And there's a question about type 1 and type 2 in the chat. And yes, I believe that this guidance is for type 1, HSV1 and HSV2. It is serotype agnostic.
Great. Covered all of HSV. And now we're going to move on back to Dr. Zucker.
All right. So this is Igor, who's a 29 year, that's you. Well, let me take control back. Sorry. Okay, here we go. Igor's a 29-year-old male who takes HIV PrEP for HIV prevention. He's sexually active with men. He has 4 condomless partners since his last visit, and is a walk into clinic between quarterly visits with 2 days of green penile discharge. So in our sexual health clinic, we did our routine testing for HIV, syphilis, and 3-site gonorrhea, chlamydia, and we treated him empirically with ceftriaxone and doxycycline. His lab results came positive for urine, pharyngeal, and rectal gonorrhea, all positive. And so he had been treated, as we mentioned before, with ceftriaxone, but he actually came back 6 weeks later. I got totally better, but now it hurts again when I pee. He'd had 7 condomless partners since his last visit, and he's very confident that his regular partners were treated for gonorrhea and syphilis, interestingly enough. What would you do now? Dr. Heumann, what would you do now for him? So he's coming back in having recurrent dysuria, essentially, after getting treated for gonorrhea.
Yeah, so he would get a new workup at this point because it's been 6 weeks and he's having new symptoms with his dysuria. We do gram stains at our clinic, so we might start there for him and see what's going on. And then depending on the results of that gram stain, some additional empiric treatments, and then probably sending off NAT testing again for gonorrhea and chlamydia to see if he's reinfected.
How much ceftriaxone did you give him?
500 milligrams.
You know, I agree with Christine that this is really we're at the point where you're redoing the workup. I think in the back of my mind, and someone who's had pharyngeal gonorrhea is, did they get enough? And we are all waiting for that person who's going to be our ceftriaxone resistant patient. It will come, and probably will come to you, Jason. It's not going to come to Detroit, let me tell you. We are not cool, but I think that, it's going to linger in the back of your mind. We are not part of GISP, but for people who are in cases like this, if you really feel, and we're not here yet, but if you really feel like this could be a treatment failure, that's when you start thinking about that.
Yeah, I think based on the history provided, as the others have said, I'm not ready to consider him a treatment failure just yet. So I'd probably just give him the 500 dose at this visit.
Mm-hmm. All right. So we did repeated routine testing again. We treated him empirically again with ceftriaxone 500 milligrams and doxy. And we actually started him on doxypep. He'd not previously been on doxypep, but we started him on doxypep. And his lab results came back positive for urine gonorrhea, pharyngeal gonorrhea, and rectal chlamydia positive. He come back 3 weeks later again. It never got totally better. It hurts again really bad when I pee. He'd only had 1 condomless partner since his last visit, and he's confident that this partner was treated for gonorrhea and syphilis. What would you do now?
Do you think it's time for gonorrhea cultures at this point? We are able to send those at our clinic because we're part of, it's now Cargos gonorrhea surveillance. So I would be curious, although we don't see much resistance, I would want to do the susceptibility testing and then think about those higher doses of ceftriaxone.
Yeah, I also wonder if his partner's also having other partners, and kind of have to go through the cascade of who's been treated and who hasn't.
I think that's a great point. Yeah. So, I wanted to highlight, because we're talking a lot about gonorrhea resistance. We're not going to go through these mechanisms, but one of the reasons gonorrhea develops resistance so easily is that it has multiple mechanisms of resistance. And so it can develop resistance multiple ways to multiple different antibiotics. And we are starting to see worldwide gonorrhea resistance. So the things in red are what I want you to look at. But we are seeing in the WHO surveillance over the last couple of years that we're seeing high rates of ceftriaxone resistance, but in certain countries. So as high as 15% in Cambodia, 20% in Vietnam. And there were actually dual resistance to ceftriaxone cefixium, and azithromycin in multiple countries, where we're seeing resistance through multiple different mechanisms. We're also seeing something similar in China with over 8% ceftriaxone resistance, including over 10% in 5 provinces. And so it's really local, but we are starting to see this. We've not seen as much in the European countries or in the United States yet. Ceftriaxone resistance is relatively rare in the European countries, about 0.03%, a single isolate from Germany in the 2022 surveillance. But we suspect that it's coming here now, coming here eventually, especially because we often see these things start in Asia and other countries and then make their way here over time. We talked a lot about how we have not seen a true culture positive case in the US with resistance. However, the surveillance network did pick up 2 cases in Massachusetts, I should say, that were non-susceptible to ceftriaxone via molecular testing. The good news is both patients did clear after ceftriaxone despite having a genotypic resistance profile, although both of these cases were in the urine, where we do know that you get very high levels of cephalosporins. And rumor has it there have been more cases since then that have not yet been reported, but we are starting to see this more and more. So we need to think a little bit about what we do when we get cases. I will say, Dr. Newman joked that I'll be the first, well, here in New York, we'll be one of the first to see it. I've been waiting, and we've been getting a lot of referrals for patients who are failing first and second line treatment for gonorrhea. We've not successfully cultured them yet, but we have started to think about using and have used several times now alternative treatment options. So I wanted to ask the group, if you have someone who's coming to you a third time with gonorrhea, you are really worried because let's say they have not had many sexual partners, you're worried about resistance, what options do you have?
I can say that we're sort of fortunate here where we're working with the state public health lab and doing surveillance. And so sometimes we get data back from that. We have a little bit more information about our local resistance prevalence. But there are a couple of oral options you could consider. Certainly tetracycline or doxycycline, excuse me, although the resistance nationwide is maybe about 20 to 30%. Quinolones like Cipro as well, but also have higher prevalence of resistance. But there are some newer medications as well, which I don't want to do a spoiler, but maybe you have a slide on it.
Oh,
So
no, it's for you guys to talk about. I'm just here to clean up.
Yeah, there are some newer medications, sort of first in class. In our clinic, we haven't been able to get access yet. I don't know if the others, Gretchen or Christine, if you've had any.
We haven't had demand for it, and so we have not tried.
Yeah, we haven't needed to use it either. We were part of the clinical trial sites here for Zoli. So we had some of that experience. Another thing I think about with alternative treatment, I am leery of using them with pharyngeal gonorrhea because we know that's harder to clear. So that's something I keep in mind as I'm treating. If I am having to move towards alternatives, I'm cautious when it's a pharyngeal infection.
Because of where I am and because we use amikacin like it's going out of style, I do need to mention gentamicin here. It is on the alternative list. It is most people who are not ID docs in places with a lot of gram-negative resistance, like their eyes bug out when you say, when you say, we're going to give, IM gent, but you can. Available. It's cheap as hell.
So I actually wanted to talk about 2 different groups of alternative treatment options. One are what's currently available and potentially available if you're in an academic medical center that has sort of an inpatient-like pharmacy, or you've just ordered it for outpatient. And the Nabogo trial looked at actually 4 different medications: ceftriaxone, ertapenem, gentamicin, and phospho. The numbers for phospho are low because it was so poor that it was stopped, or that arm was stopped early. But what they actually found was that single-dose ertapenem was non-inferior to single-dose ceftriaxone for uncomplicated anal genital gonorrhea. And single-dose gentamicin was not non-inferior to ceftriaxone, although the thing I want to highlight for you is sort of where it fell in the non-inferiority margin. It's technically inferior to ceftriaxone, but not by that much. So I just want to highlight the fact that that is a good option. And because it's the alternative regimen recommended by the CDC, it's often the one that people have in their clinics, especially for patients who might have cephalosporin allergies. And so while this study says that it's not non-inferior, it's also not bad. You can see where fosfomycin fell here. That's obviously not something I would use. If gentamicin was available, it is something that I would certainly think about using. And then we have the two new medications that Dr. DiMarco mentioned before, Jepo and zoliflodacin. I can't pronounce either of them well, but they're both first-in-class antibiotics, which is really exciting. And both of them have been shown in 2 randomized controlled trials to be effective against genital urinary and rectal gonorrhea. In both cases, the data for pharyngeal infections was lower than we would like. So just really important to highlight the fact that these were demonstrated for urogenital and rectal gonorrhea and not necessarily for pharyngeal gonorrhea. But it's great that we're going to potentially have 2 new oral options on the horizon very soon. I imagine initially these may be expensive and harder to get, so just something to keep in mind. But we will hopefully have 2 new options very soon that we can actually get. Going back to Igor, he came back, we did our repeat testing, and we did do a gonorrhea culture this time. And we actually treated him with Gent and Azithro, which is the alternative regimen, because he had come back so many times. His labs came back positive again for urine and pharyngeal gonorrhea, and we got antimicrobial susceptibility testing, which showed that it was resistant to Cipro and resistant to tetracycline, but very susceptible to cephalosporins, really suggesting maybe a reinfection as opposed to treatment failure.
And I think you have the suggestion, someone put it in the comments there, that he got rectal chlamydia in this whole thing, suggesting that there is a larger network at play.
That's right. And that was when he had come back in reporting 7 recent partners. And so we were very worried about reinfection then. The third time he came in, he said he was just with his primary partner. And again, his primary partner may have other partners and other things like that. But we were a little bit more worried about resistance at that time. But again, turns out we were wrong. For those who came to the Doxy Pep Talk the other day, we talked a lot about tetracycline resistance rising. Dr. DiMarco talked about the 30% nationwide stats, but the Kings County data suggested that very shortly after going live with Doxy Pep, rates increased from the 20% range to the 70% range. And so I suspect we're going to see a lot more tetracycline resistance as surveillance continues. And just something, again, to keep in mind. The good news is that his symptoms resolved after treatment. And so he did get better and didn't come back for a few months after that. Excuse me. Just, as a reminder about antimicrobial resistance, it is something we need to think about. It's something we are all going to see in the future. I don't know if it's going to be 1 year or 3 years from now, but we certainly are all going to see it. We're already seeing high rates of ceftriaxone resistance in Asia and then sporadic cases in Europe and the US. In terms of treatment options, the Nabogo trial said that ertapenem was the one that's non-inferior. We have used that twice here, but gentamicin is also an option. And then we have the 2 new Jepo and Zoli meds coming soon. But the key challenge really remains pharyngeal gonorrhea because neither of those showed as high rates of cure as we would like. I talked about in the Doxy Pep one, but vaccination, which we didn't talk about today, but the UK rolled out vaccination for gonorrhea. And the RCT evidence is really less convincing there. And so I won't go back into that again today. Why don't I turn it back over to Natalie? Do we have anything in the chat or the questions, Nat?
There's a question, is there any evidence that increasing the dose of ceftriaxone from 500 to a gram can clear a treatment failure?
You guys want to talk about that? Because I know you guys mentioned before the possibility of using a higher dose.
I don't know of great evidence, but we have done it in our clinical practice. So if someone's coming in for a retreatment, sometimes we do give a higher dose, even if it's not indicated by weight.
We've done that as well. Yeah. Go on,
Similar for us, and I think there might have been some case reports. The UK, I think it's the UK, has actually changed their guidelines so that 1 gram is actually their standard dose for initial treatment, based on some of the data and information that Dr. Zucker had shared earlier.
Yeah. And there's some data that there's some MIC creep worldwide. We haven't seen as much MIC creep in the United States, but other countries have started to see that, suggesting that a higher dose may be beneficial for those people.
There's a comment, we adjust it by weight. Is there a new guideline for it?
Yes, the new guideline is weight-based. It's a threshold weight though, so to echo what everybody else is saying, particularly if someone's scrunching up towards that threshold, and particularly for pharyngeal where we know the penetration is lower, we will often be aggressive, seems like the wrong word, permissive perhaps in our dosing. And we'll
It's
push
150 kilos too, right? So
it's like really big, but for a lot of people,
yeah,
I think they need more. And just remember, for those of you who don't do inpatient ID medicine all the time, a gram of ceftriaxone is nothing.
Yeah.
So,
we haven't really been saying it, but the gent is combined with
Zithro.
Azithro, so that everyone knows. It's just, even though that study showed that it was like monotherapy with gent, it is recommended that it be combined with, I think it's 2 grams of azithromycin.
And that's what we did do in that case. You got Gent and the Zithro.
All right, I think we're good. Wait, I see one more question in there. And 2 grams for greater than 150. I guess that's 2 grams of azithro. Yeah.
I think
No?
he's talking about 2 grams of ceftriaxone for people who
Ah.
are over 150 kilograms for treatment failure. I defer to you guys. I've not run into this. I've not done it.
I've never done that.
I've not done that. I could see how that might also be incredibly painful.
Yeah.
So I would have to think about that a little more. I haven't personally done that, but if you found yourself in a situation where you wanted to give that higher dosing, you might be separating them into different sites.
I think at that point I might be choosing a different agent.
Yeah, I think so.
To go up on that. Or the other option, if you have it in your clinic, would be placing an IV.
IV,
Give
yeah.
the 2 grams via IV. A lot of places can't do that, but some can. But that would be the other option, to give 2 grams in a little bit less painful way.
I don't know. I don't want to, I know we've got one more case that's going to be complicated, but I do think it's important to talk about why culturing gonorrhea is so challenging and why there are cargoes, formerly GISP, and we don't all just send culture. It is hard to grow. It's the sensitivity of culture back when we were doing penile meatal swabs, even for people who had the green drip, right? Gonorrhea is the drip, was low. And so I think that part of why you're hearing so much concern about, are we missing resistance? Oh, we have these treatment failure cases where we're not seeing evidence, is that culture is insanely insensitive here. And so NAT testing was incredible, was revolutionary in the treatment and diagnosis of gonorrhea and chlamydia in the way that we would love for it to be for syphilis, but it has not yet been.
And just to highlight some of the reasons, you have to maximize your yield, you need to plate it within a short period of time after collection, which means if you're sending it to a lab, it's also often too long. You then need to incubate it in special conditions, on special medium, that the best medium costs a lot of money per plate. And so many people won't use that one. And so it's just really hard to grow for all of those different reasons. When we really want to grow it here, we will literally walk it down to the lab and let them plate it right away to try to maximize our chances of growing it, which not everyone can do.
Which not everyone can do. We can't do that in Detroit. It's not feasible for us. And we are an academic clinic. Like, we're an academic health. We are the premier health department in Michigan, and it's not possible. So I think it's very real for people who are not at Columbia that it's just not feasible.
Yeah.
I was going to say, back in the day when I was in the Ipsy clinic, Ypsilanti, we used to have the plates, the chocolate agar in the clinic. We would take the swab, plate it right there, put it in one of those containers, light a candle on top, lock it up, and ship it away to create the right conditions. Dating myself a bit, but
Yeah, we inoculate them in our STD lab, so that we can get started with them and then move them over to the main lab of the health department with Cargo's funding, though it's very expensive. So Cargo helps us pay for this.
That's right. And that's the way you're going to get the highest yield, is you do it right away.
Mhm.
Which is not feasible for most people, quite frankly.
No.
Yeah.
it's great that you can do that. Amazing. All right, we'll move on to our last case. This is a 17-year-old who presents post-sexual assault. He's presents to the ED 48 hours after an assault. Past medical history is that he has sex with men. He's been on PrEP, but is not consistent for the past 3 months. He reports that he passed out at a party and now he has rectal pain and bleeding. In the ED, you do your evaluation. You do gonorrhea and chlamydia and gnats at 3 different sites. You review his immunization records for hepatitis B, and you do blood testing for HIV, HCV, syphilis, and hepatitis B, as well as creatinine and liver function tests. What else should be done in the ED? And this is probably, you know, a multi-answer thing for most folks, but would you assess for partners, practices, past STIs, and protection, as we've been sort of harping on for the last 3 days? Treat for gonorrhea and chlamydia, treat with doxy and moxifloxacin, assess for GI pathogens. He says that he has rectal bleeding with a PCR. You would start him on HIV PEP with raltegravir, tenofovir, and emtricitabine, or would you start him on HIV PEP with Biktarvy? And it might be several of these. So 71% say they would treat for gonorrhea and chlamydia with ceftriaxone and doxy. A bunch of folks also want to ask the questions about partners, practices, and past STIs. That is always a good thing to do. Some people want to start PEP with raltegravir, and some want to start it with Biktarvy. So we've got a smattering of all answers, but most people want to give treatment for STIs right away. Our panel, what do you guys say? What are the guidelines around sexual assault?
So it is recommended to go ahead and treat for gonorrhea and chlamydia. We would do that. And it seems like PEP is also indicated here. There's variable practice in which of these 2 regimens to choose. In our STD clinic, we do use Biktarvy for PEP, but the other choice would be fine too. Maybe just a little bit harder to administer, just it's more pill burden for the patient and a twice-a-day administration with the raltegravir.
Anybody else?
Yeah, I completely agree. And if you couldn't get Biktarvy, if you could at least get the dolutegravir with tenofovir emtricitabine, that would be better than the raltegravir option, just for adherence purposes.
I also am
And-
going to just weigh in here. Yes, this is medically what you need. This patient also needs a safe exam or a sane exam and needs to be treated comprehensively for his assault. We forget about this in the STI world because often they come to us after this has happened, but we have run into this over and over and over again as a referral center for clinics outside, is that the sane exam doesn't happen for people assigned male at birth almost ever. And then they are not referred to the appropriate resources for people who are survivors or victims of assault. And so I think it's important that we roll that in our mental model for how we're doing that. When they call us, we also need to remind people, particularly for people who are assigned male at birth, that all of the things that you would do for a sexual assault for someone assigned female at birth apply in this case as well.
Excellent point. And a lot of what you're going to give depends for PEP, depends on what your pharmacy allows you to have, which we're now having ongoing discussions at Columbia about that because of the cost. Biktarvy is much more expensive compared to the other regimens that we discussed. So yes, again, just to reiterate to everybody, you're going to want to treat for STIs with the regimens that we've mentioned in the past. Just to note that it does also include metronidazole in the guidelines, especially for female assault victims, which this one is not, but in order to treat also for the possibility of PID, we would want to to make sure that that was included for the women. It does make it difficult, and it can increase the issues with nausea, but make sure you consider that as well. So the patient tolerated the ceftriaxone and was taking the doxy, did get the medications raltegravir, tenofovir, and emtricitabine, but it made him incredibly nauseous and he was inconsistent. His labs came back and it showed that the chlamydia was positive in the rectal swab. The RPR was negative, HIV negative. The rest of the labs you can see here were negative, and he does have an elevated inflammatory markers as well. Oops. I don't have a question there, but I wanted to talk about in this situation, just for people to think about like proctitis and proctocolitis in this situation. He was complaining of bleeding, rectal bleeding and pain. And although it seems like crazy to have a GI PCR, you know, to be done in that situation, you might consider it, because if he is having symptoms and significant abdominal pain and cramping, he could have a GI pathogen. We are seeing that in many of our MSM patients, including presenting with, for example, Shigella or Giardia. So it's something to consider in that situation, especially if the symptoms don't get better with the treatment that you're currently giving.
I also think you want to make sure that you've done a thorough rectal exam and a process, you know, potentially even with anoscopy. You know, if he really passed out and woke up with rectal bleeding, you're also worried about direct trauma to the anus and rectum. And if you miss that, that is something that can lead to stricturing. It can lead to a lot of problems for him later on. So I completely agree, Natalie, and would just also say when the ED is calling you, make sure that they're doing all of the stuff that requires gen surge as well.
Absolutely. So what would you do about his nausea and the problems with the medications that he was prescribed? And we sort of discussed this a little bit. Would you restart his raltegravir with emtricitabine and tenofovir? Would you change him to dolutegravir? Would you stop it because he's been inconsistent? Would you call the PEP hotline, or would you switch over to Biktarvy? So it looks like more than half of the folks want to switch over to Biktarvy. Which panelists, any discussion on that?
Might be difficult to actually get it approved, to get a different regimen approved by insurance in a timely manner, depending on what their coverage is. Sometimes I try anti-nausea medicines with the original regimen as a different way to approach this, because they already have those medicines in hand, and they can keep taking them, and maybe it works okay with some anti-nausea medicines.
Yeah, and I think that Christine makes a really important point. One of the challenges with Rel is it's BID and he's 17. And I was 17, and, you know, brushing my teeth BID was a success for me. And so I think that a Q-day regimen, you know, dolutegravir, emtricitabine, tenofovir, we're having better luck getting covered because it is fully generic. And remember, you're going to use TDF here, not TAF. We have no reason to believe that it is a different effectiveness, but TDF is certainly safe for this kid, and it is cheaper. We love cheap. And that might get covered. And then I really agree with anti-nausea medication. You just need to get him through 28 days.
I'm curious, you know, since he is 17, New York state laws require our ED to give the full 28 days of meds at the time of discharge from the ED. I don't know if the same applies to your states that you're in.
No.
So we have
And
multiple
actually,
states here.
in February, we're going to be required to provide 28 days to all sexual assault victims, not just those under 18, which was the previous requirement.
That's amazing. That's great. So hospitals, that's also why we're struggling now to get to
This is where the
Biktarvy.
cost comes in, because we used to do starter packs, and then it was our job in the outpatient setting to fill the rest of it. Now we have to provide a full 28 days to people, which obviously adds to the cost.
we're in a starter pack world and we use samples for it. And for patients where we struggle to get it covered, we've not had a big, for most of our patients on Medicaid, it is covered without issue to get Biktarvy, a 1 pill once a day regimen with a 2nd generation integrase inhibitor. For people with private insurance where it's challenging, we have on occasion just given them the sample of 28 days.
So you gotta plan and do a lot of workarounds. So he was changed to Biktarvy, but he couldn't fill a prescription and didn't tell you. And he returned 3 months later to get a test for reinfection for chlamydia. On discussion, he reports a rash, fever, fatigue. He says, I really want to restart my PrEP. The HIV testing was performed with a antigen antibody that's positive, but the confirmatory was negative. What would you do? What do you think, I guess?
You have to be worried about acute HIV and get your HIV RNA test, which might, in some states, including New York, it's done automatically in this scenario, and sometimes you have to ask for it separately. But certainly you could consider other STIs as well. We see a lot of syphilis, and so you always worry about syphilis, which can sometimes have these systemic symptoms, but certainly new rash.
Anybody else?
I wouldn't restart PrEP until I had his RNA testing back, because we really need to decide 2 versus 3 drugs for him, and does he have an HIV infection or not.
So when I teach this case, this is the case that I teach to all of our inpatient, all of our internal medicine residents, is that this is the one time that you're allowed to send an antigen antibody and an RNA at the same time. Because we deal with so many different labs in-house here, like you were saying, Daniela, it will automatically reflex, but in a lot of the community, particularly outlying community hospitals, it will not. And so if you are concerned about acute HIV, and you should absolutely be in this situation, that is the one time you get to test, you get to say your screening and your confirmatory at the same time. Otherwise, I will light you on fire for it. And then I agree, you really have to be worried about syphilis here. So what would I do next? I'd give him a shot of penicillin and send labs.
Perfect.
So now that asks a critical question here. Is it antibody or antigen positive? You cannot break this test and find out. So in some tests, you can physically open the cartridge and figure out which line was positive. The way that this test works, you cannot break that cartridge open.
There are also other tests that do report antibody antigens separately. This one does not. The one we use here does not. So you often don't know here, although there is a 5th generation test that can tell you which one is positive.
Yeah, we get ours reported out separately, so it's interesting when you see that antigen positive, you'll have that higher suspicion for acute HIV. And
so unfortunately, he did have acute HIV and came back with a viral load of over 10 million when he returned for the visit and started on antiretrovirals and is doing well. So just wanted to reiterate to everyone that post-exposure prophylaxis for HIV is really, 72 hours. We would like that to be done. Various scenarios, needle sticks. We did a sexual assault here today. It is a 28-day course of medications. As we mentioned, there are various medications that can be used. Really working with the patient and making sure they're tolerating it. And I can't emphasize enough, like really checking in to see if people actually got it. Like we see patients and then we send them out and we're like, just do this. And sometimes that it doesn't work. They aren't able to pick them up for some reason. There is, oops.
That would be because that has to be our last slide because of time.
Oh. Okay. Just to say that there are studies that show that Biktarvy now is, and most folks are moving toward that, but with the cost issue for to use it in PEP is a significant issue, and hopefully that'll get resolved over time.
This kit is the use case for lenacapavir for PrEP. I just want that out there. Like this would not have been an issue if we'd been able to put him on lenacapavir at the time of his sexual debut.
Perfect, because the next slide was going to be what other prevention things we could do. Maybe not in this case, but in other cases. Well, we really appreciate all of you coming today and talking through these cases. Did an amazing job, covered all the points that we wanted to cover. The audience obviously had a lot of great questions. I think there's one that's in the queue. Are we allowed to do that, or do we have to sign off?
Oh, you can go ahead, Nellie. It looks like it's a comment.
I believe Gilead is
Okay.
able to provide 1 round of PEP free of charge. Not sure if patients have already have to already be enrolled in GAA. Good to know.
Great. Thank you so much, everyone, for attending 3 full days. We know that that's a lot of your time to spend with us, and we hope that you enjoyed it and that it was a good experience. We certainly enjoyed having all of you, and it was great to see so many of you stay with us consistently through these 3 days. I would like to thank all of our panelists. This was incredibly exciting, very interesting, and we enjoyed working with all of you today. So thank you for your time. Just wanted to do some wrap-up items for our audience. So first of all, we will be sending out slides and resources and CE instructions on Monday. So you should be receiving an email for that. We will also send out an evaluation for these past 3 days. And then finally, we will be sending out the Qualtrics link once more time. However, it is also in the chat. Please remember that you must complete that in order to get CE. And so that is a very important link. And other than that, we hope to see you at a future STI intensive. We are tentatively planning to do this again in March of 2026. So we will send out dates if anyone would like to take the course again. But thank you again for attending, and thank you to all of our speakers. We hope it was a good experience. Thank you.